back and diabetic since 1 year. Presented with sudden onset of chest pain, window period 3 hours. An examination of pulse rate is 38 with clinical signs of AV dissociation, canal waves, and an auscultation bearing S1 is there. Blood pressure of 120 by 80. And the ECG is at the presentation. This ventricular rate is 40 per minute, and there is a QR pattern in V1 with chest elevation in V2 and V3, and there is chest elevation with QS in the lead 3 and AVF, and there is high grade AV block.
No, this is yes, sir. Small R yes, sir. That is yes, sir. That's not QS. Inferiorly.
Yes, sir. That's LA.
Because whenever you have a
this LA is and the 2D episode RWM and LAD therapy and mild LV dysfunction, no MR. Emergency DPA external loop, and this is the angiogram which showed the right corner injection was normal, L6 was normal, and in the LAD is a proximal total occlusion of the LAD, and we did primary PTCA to proximal to mid LAD 3 to 18 mm DES. And TPA was removed 3 days. She was treated with dual antiplatelets, ecosprin and ticagrelor, and statins and other supportive treatment. TPA was removed 3 days later. There was resolution of high grade AV block to reversion to sinus rhythm. She was discharged in stable condition. So this is the ECG before discharge, showing QRBP, and this patient is in sinus rhythm. So 3 days after discharge, she was again presented with 2 episodes of syncope, and she denied any chest pain, palpitations, and dyspnea. The patient was conscious, correct. Neurological evaluation was normal, and vitals are normal during presentation. So at this junction, what are the possibilities? Is it a vasovagal syncope? Is it any conduction abnormalities because of bradyarrhythmia conduction block previously having, or it is a tachyarrhythmia post-MI patient, VT or VF, we don't know. So, and this is the ECG during second presentation. The ECG became now RBBB. So she developed RBBB, and the axis also changed as SARS at the no, that is Q. Sir. No. So before discharge, this is Q. This is Q.
Yeah,
The morphology looks like
it looks like
that. The QR or the thing. Go to the previous first one. See, here it is there is RBB and left axis deviation.
Yes, sir.
So there is bifascicular.
Bifascicular blocks.
And probably the third fascicle also got
No.
disease. Problem.
No, run the angio. Normal. Please run the angio once.
Learn. Normal. Normal. No, it is codon net, sir. Codon net.
Basic, I mean, anterior MI complete heart block, he should be in calcium shock. Because unless he develops complete left bundle, I mean, including fascicles, posterior fascicle, it's an extensive MI, and most of them require permanent placement. And the prognosis is very poor because, I mean, if he's in shock, it is different. Otherwise, it's also 50% mortal. So, but whatever you have seen, whether it is an
coincidental primary connection system disaster. And majority of the times, at the antrum, the QRS will be widened with the complete heart block. You don't see that the narrow QRS.
Here, the thing is that selectively conduction system central artery only got occluded. With the TV1 for distal LAD and diagonal is well preserved. Probably that's why myocardium to conduction system ratio damage is much higher. Conduction system is might have relatively more damaged here. Maybe basal septum only might have involved where there is. No, in that case, you get complete complete heart block unless it involves only selectively HV. I mean, no, that's why I want to see RCA. Bundle or AV node. AV node cannot be involved in anterior. Yes, sir. His bundle maybe, but rare. Generally, if it is an anterior MI, it is all these fascicles, both fascicles and right bundle are blocked.
Patient was admitted and mounted in ICU. Mounted in ICU again, she got sudden onset of syncopal attack while lying down after 2 hours. So at that time, we were able to take the ECG, it is showing non-conductive TAF, AV block with escape mechanism almost for 8 seconds. And it is continuing, we did CPR. So at this juncture, CPR and atropine, everything were given. So resuscitation we did. At this juncture, what are the possibilities? Is it ischemia related because of reocclusion of infarct related artery, or because of drug induced, because ticagrelor are also known to cause AV block, and is autonomic mediated, sometimes hypervagal mediated can cause a block, and is it a conduction system disease coincident? So we did emergency temporary pacemaker via right jugular route and check angiogram which showed patent stent, and there is a small septal artery also we can see. The L6 is normal. So this is the post TPA ECG. Here, patient is in sinus. Intermittently, she is requiring the pacing. So here.
But here you have a RBB. There
RBB.
is no Q.
Yes, sir.
There is no Q. Probably this patient is having a incidental
Incidental
conduction
conduction
system disease.
Incidental.
But you have MI at the
And
same
this
time.
Yes,
That is responsible for whatever
For-
we are seeing.
yes, sir.
And he requires a permanent fix.
Yes. So the possibilities were ruled out. This patent LED stent and ticagrelor stopped for 3 days, and we have waited for that. And atomic mediated, it is more commonly described in info MI and conduction system disease. So we have to rule out. So what is the next plan of treatment? Whether to go for conservative or permanent pacemaker? Conservative management, if it is ischemic related, we have done within window revasculate within window period of 3 hours. Sorry. And the patent stent check angio, and patient is in sinus rhythm, not dependent on TPA after that.
Sir.
And if you go for PPA in the acute coronary syndrome, there will be increased risk of bleeding as she was on DAPT, and infections are more. And not, but not the least, financial implications are also there. So shall we go for permanent pacemaker? Because the factors which favor permanent pacemakers, because AV block without any escape mechanism, and the syncopal episodes even after shifting to clopidogrel, and the ECG showing intermittent bifascicular block, initially LHB, then right axis LPFB. So there could be both combination of ischemia and underlying degeneration. So after this discussion, we have done pacemaker, sir, dual chamber pacemaker. After that, she is doing that.
So in these cases where you have dual antiplatelets, it is better to take the help of a surgeon to make a pocket. Yes, sir. We are doing permanent pacemakers on our own, but if we take the help of surgeon during that time, we will get better hemostasis. So
Surgical skills.
Surgical skills there. It's not a leader. It is whatever it is. See, they use cartridge better than you. They make a pocket better than you. See, that cellula. How many of you remember know about that cellula? How many of you know about that cellula? Okay, only Jeevan people will know. Cellula. He is the first DM cardiologist, qualified DM cardiologist, mammal, bhagya and cellula. So he was our head of the department. He used to put a pacing lead, but everything is done by a surgeon. And that time only Catholic. We used to do more Catholic approach. So what I am trying to tell is, whenever you require in such case, better to take the help of a surgeon to avoid whatever complications you are telling about, hematoma, infection. Maybe.
We are doing regularly on DAPT, even on anticoagulation with INR around 1.5. We never used cartridge in Jayadeva, but after coming here, I have learned that thing. Once we started using cartridge in terms of
That's what I'm saying.
almost less. We have to learn.
Yeah, because
Cartridge makes your
I am
life
talking,
simple.
you are an electrophysiologist. So you are doing more number of procedures or more number of ICDs.
Yes.
So you learn that
Yes,
technique.
sir.
But most of the youngsters who are putting pacemakers outside, they will not be doing so many procedures so as to learn how to use cartridge. That's what I'm saying. Okay, thank you. Evening, light layer.
లైట్ ఏముందండి డాక్టర్ మూర్తి చెప్పండి ఆపుతుంది APCSI children, sir. We need some comments on this.
Rehan is my senior. I think who knows more about how to create and how to treat complications. Now create because he gives a lot of hand to the
See, this is basically a renal embolization procedure.
Good afternoon, everyone. This is a continuation of previous presentation by sir. Clinical details: 32 years male patient underwent PCN and outside with a bilateral lesion for a renal calculate, and post procedure patient developed persistent hematuria. He was evaluated for hematuria from a urological side, and after evaluation, they found CT abdominal was done, and the CT renal angio also was done outside. They found right hypotension and a hematoma connection the right pelvic axillary system. So clinically, they have suspected some either iatrogenic trauma after the procedure or AV malformation, and then they have referred to us for further back. Here we have done a renal angio, self-renal angiogram of them. And yes, sir. Here we're able to see a trickling of blood from the lower segmental branch of the renal.
Please. Actually, we thought we could not find a blood source initially, but after careful watching, yeah, please. And yes, of course.
Even the trickle flow is here.
Very good. So,
Yes, small trickling is there,
Yeah.
but unless you see, say, we can't find.
yes. We did a couple of cases like this post PCN and renal blade, but the majority of the times
So
we
we
used
used
to.
to trickling of blood from the below second segment ladder.
That is it.
So then we selectively engage with the segmental branch of the renal artery. Then now our intention is to block the segmental renal branch, which is the culprit. So the issues for is using the embolizing agents, but to selectively deliver the embolizing agent to the segmental branch, we don't have the microcatheter which is suddenly available at that time. And even though we have the available microcatheter with us, we're not able to deliver the PVC particles because the size of particles are large and the gel form also not able to deliver. So now we have identified the culprit with it, but now we're ready to embolize the selective segmental branch. Now we have options with us the PVC and gel form. We have it us, but we're not readily available. We can't deliver to the desired
Very subsegment.
subsegmental branch. So then we went to develop an indigenous technique.
Yes, Ramdas. So please. So what we did is please show. Yes.
We took a stem balloon and we fragmented the stem balloon into fragments, 3-4 fragments, and then we loaded the fragments of the wire. So that way, we loaded the balloon. So that all these 3 particles, with the help of balloon batter, we will deliver to the desired location.
We took the curtains of the G balloons, we threaded over the wire, and we took another balloon distally. And with this balloon support, we pushed these balloon fragments into the subsegmental artery.
The distal tip of the
Distal tips we cut like. So these are the
distal tip of the this thing with which you block.
yes. With that we embolized this, we left it there in the distal subsegmental artery. This is they pushed into subsegmental artery and we left it there. We took
Three coils to
we do. And this technique will definitely help us even in the distal coronary perforation, because most of the times the wire will be there in there itself. Suppose we cannot remove the wire, we can give this material, this standard balloon material, because we can easily thread on the coronary wire and we can push it.
No, but
Distal,
you have a hole, no?
Huh?
You have a hole on the distal
Yeah.
tip.
yeah, we'll thread it on the wire and just
No,
push it.
You have pushed. Okay.
Hmm.
You have a hole on the in the distal part of the.
Yes.
No, it will automatically get thrombus. It will automatically get thrombus.
Immediately, Thomas formation is there.
రాలేదు సార్ అది ఒకసారి తీసిందట అంటే we entered the subsequent artery, we kept all this material in the subsequent artery, and the ostium of the vessel we inflated this balloon. Very good, very good. Keep it up.
Even skin tag and.
Why three, sir? Why so many? You took only 2 particles into solution.
You can take why because if you take more, the chances of occlusion will be more.
Even as you said earlier, sir.
The ideas matter bale asne
Skin
meeku.
tag
So come.
and buckle also can be taken as a.
So that's how we deliver. It is a
Marker
Sir, very innovative.
innovative. Super.
Marker, one piece, one marker.
Fragmented balloon particle loaded the corner and transfer to the area of the cell.
That's your right, sir.
Actually, very cost effective.
Very cost effective, very cost effective.
Recycling the G-bill.
Recycling.
Cost effective.
అంటే దీని ఎంతగా వాడుకోవచ్చు.
And we have a catalog trash. What he calls is a catalog trash. But with the help of the catalog trash only, we have used many number of health patients. VDC and coils.
So
We deliver these fragmented balloon particles to the segmental, selectively we are able to deliver segmental bands of deliver. And again, we did proximal balloon tank to enhance the thrombosing process. We place a wire in the lower branch and proximally we place a balloon, fed balloon, and we inflate it to higher pressure to enhance the thrombosing process. The final angio shot.
So that's how we
To complete the segmental branch is completely active. No using for prematurely subsided completed 24 hours of patient discharge. In this case, compared to conventional ambulance which like pelvis or gelfom, we are able to deliver the fragmented balloon particles with culprit vessel without causing much tissue damage. And also without causing much renal ischemia also. Also selectively engaging the small segmental arteries of discal. And balloons are readily available in the catheter, hence can be used when conventional sources of embolizing agents are not readily available in case of emergency, even coronary situation. Actually, we don't have any data.
I think we need to publish this.
Studies.
If after deploying so many balloon pits, still it is leaking, what will you do? It won't leak.
It won't leak. Because it's a very small artery, we presume that it won't leak. In order to occlude the other vessel, we did a balloon tamper to the main vessel. We occluded the main vessel for some time. So, to enhance the thrombosis and suppress it.
Gel foam is readily available in any operation theater with the surgeons. You can take the small scrapings of the gel foam, mix it with the contrast, and then inject it. That works wonderfully. One of the cheapest ways of embolizing.
Here, in this particular case, the main problem is it is a subsegmental artery. See, gel foam particles, if you need to inject into the subsegmental artery, with the conventional microcatheter, we cannot push gel foam. We need a large vessel, large scalpel. And with that acute bend, we cannot enter that subsegmental artery. Further, to inject gel foam particles in this particular case, we need to occlude a larger vessel in the proximal area. So instead of occluding the larger vessel in the proximal area, we selectively embolize that very small subsegmental artery. You can clearly see that acute angulation of subsegmental is almost 90 degrees. It's very difficult to push, take a bend with an additional device like additional microcatheter to cross that and enter that. Yes.
And you can go into the artery and measure a coil. Another problem we usually encounter because we have done many cases. Sometimes you cannot even enter the main branch also because it can come as a 360 degree spread.
physically event. In that case, we have failed also. In that case, we cannot go without a microcatheter. This technique doesn't work. Even microcatheter also, even wire entry is also very much difficult. Well, without microcatheter, you won't cost. Not to end microcatheter.
And another device which we routinely use for embolizing is thrombosectional catheter. Thrombosectional catheter, we can put in thrombosection and we push the material through the thrombosectional catheter. That also works.
Keep GP there.
Huh?
Situation. Inventions come under situation. This thing I saw with Dr. Krishna Kumar in Amrita Cochin, pediatric cardiologist. He does all like these things, all something innovative like this. After that, I saw you.
Yes, something
Nice.
The closing session. The session one which was supposed to happen at 9 to 11:30 will happen here. Vijay sir will have it.
No, actually, Dr. Yudhishthir is supposed to talk on guide extension, but he's not here. He's here. Dr. Yudhishthir, can you hold on? Can I talk? Sorry. This is, nephrologist is supposed to talk before me, Dr. Sridhar. Not here. This is actually a industry-sponsored event. Our dear Somashekar was supposed to talk. He buckled out of it. So this is actually Novartis-sponsored event. So the slides are prepared by Novartis. That's my disclosure at the beginning. But at the same time, there's no harm in discussing a few things about army because it's an important drug. I'll talk from here or from there.
You can talk from there.
But at the most like.
Oh,
Give the pointer.
Okay, that's all. So we can just have an informal discussion. We heard a lot about army and its usage. We all have been using army for a long time. The discussion today is only CKD with army. That's a basic topic. So CKD part is a safe to use and how the problems which we face. That's being discussed in the next case here. So they have put a case and then discuss based on that imaginary case. So and then the physician, the nephrologist will talk later. So I will talk from the cardiology perspective. I'll skip these slides. There are about 30 slides which the nephrologist is supposed to speak. I have 30 slides. I'll finish in 10 minutes max. From the cardiologist perspective, it's a different case here. It's again, the disclosure is that it's an imaginary case. An entrepreneur with CKD for 5 years, she has breathlessness. So the question is whether breathlessness is because of CKD, fluid overload related issues, or is it something else? This lady, let us assume she is some 50 years old, underwent an echocardiogram, and the echo showed an LV ejection fraction of 28%. With EGFR of 36. So she is in advanced CKD. And so she has associated with that HFrEF as well. So how safe it is to initiate, what are the problems which we are likely to face from a cardiologist perspective is discussed in this case. To initiate ACE inhibitors versus ARNI is the first question which we have to answer here. And there are some evidences which has been put forth which shows that ARNI is of course better than ACE inhibitors in this patient as well. So CKD can produce heart dysfunction from stage 1 onwards to stage 6. So there is no, it's like a continuum of events, and you can see that a lot of mechanisms by which CKD can produce heart dysfunction. And also they say that even out of patients who go for dialysis, almost 7 out of 10, so 70% of patients have heart failure of some severity when this by the time the patient reaches dialysis. And as the duration of CKD increases, the incidence of underlying heart disease also progressively increases, reaching up to 70% by the time they reach dialysis. That is stating the obvious, but putting it in clear terms there, that patients with CKD and heart failure do very bad at the end of 1 year, and they go on to do even worse at the end of 2 years. So it's like a double whammy for our index case as well. The problem is that most of the drugs which are well validated in heart HFrEF, we underuse in CKD because we are worried about hyperkalemia, we are worried about hypotension and all the other issues. So we tend to underuse them, but these drugs actually work well in these patients, probably better than what it works in a regular patient. When I say regular patient, an HFrEF patient with normal renal functions. So 2021 APCSI guidelines, actually, we are all read it, that now the approach is to not to initiate, and I don't have to start ACRP and then shift to ARNI. You can directly restart ARNI, and we have all been doing it by now. And I'm sure we are all quite comfortable with that as well. So we have come a long way from omapatlat, which had problem with ACE. It was an ACE plus neprilysin inhibitor, which had increased incidence of angioedema. It did not get FDA approval. FDA meet actually Bristol Myers actually a product. Unfortunately, it went out. It was people thought that was the end of neprilysin inhibition inhibitor drugs completely, but then fortunately for us doctors and for the patients as well, the ARNIs came into picture, which is actually an ARB plus an neprilysin inhibitor. We know the mechanisms, we know how they have a complementary mechanism of action, and we also know that angioedema is much lesser with this combination because there is no ACE inhibitor activity here, unlike omapatlat. It is a direct angiotensin receptor blocking activity. So the dreaded complication of angioedema is lesser, and you can also see that the outcomes in CKD patients with HFrEF in all the events are significantly lesser. Mortality, hospitalization, and CV death and HHF are all lesser when ARNI is used in heart failure patients with CKD. So compared to enalapril here in this, the gray bars represent enalapril and the yellow bars represent CKD, sorry, ARNI. So these are not direct comparisons. These are only historical controls versus the active drug. It actually says that patients, if you CKD patients initiated with HFrEF, initiated on ARNI, actually have improvement in GFR with passage of time. Again, not a head-to-head study, not a case control study. It's basically historical controls matched with active cases. A very small number of cases. If I remember right, this was only about 50, 60 patients. Nevertheless, it points out to some benefit in CKD patients as well. So there is significant improvement in heart function. As you can see, CKD patients do better with this compared to historical controls if ARNI was initiated. So it's suffice to say that this works in stage 1 to 3, 14% reduction in HHF if you initiate ARNI in CKD patients stage 1 to 3. And what about 4 and 5? Even a better improvement. So 28% reduction in death and hospitalization. Sorry, it's not HHF alone. It is CV death or heart failure hospitalization when ARNI is compared to enalapril and compared to the standard heart failure treatment in a real world setting. So that is to say that all stages of CKD, ARNI is safe to use, and actually the nephrologist discussion actually talks about the risk which we fear about, the hypokalemia worsening. That's another part of the talk actually that should have come first. But nevertheless, we are worried about hypotension because most of our heart failure patients have blood pressure of 90, 100, and we are scared to initiate, forget about up-titrating, to even initiate the drug. But what the remaining slides show us is that these patients actually, how to manage hypotension in our heart failure patients, what are the steps, and that is how to break the cycle, that is HFrEF itself produce hypotension, your drugs worsen it, so how to break the vicious cycle. That's being discussed in the next few slides before we conclude. So important to know that many a time the usage of these drugs like RAS inhibitors and ARNIs actually can lower the BP. Lowering BP doesn't mean that it is complication. It is actually means is that the drug is working properly. Because many a time it's a peripheral vasoconstriction because of high RAS activity, which produces your 110, 120 BP or whatever you get. And when you initiate these drugs, it antagonizes the RAS activity, and actually there is a decrease in afterload, which you detect as a lower BP. So essentially, lower BP means to an extent that the drug is working as well. So, but how low is the question? How low can you comfortably go? That is what the slides say. So first of all, you have to link the low blood pressure with symptoms. I will skip a few slides. This is actually a very good, and this is available online as well. I checked it subsequently. I saw the slides in the morning. It is available online. Very useful algorithm actually. When you see a hypotension patient, first confirm that the patient has hypotension. Sometimes you may require ambulatory BP for that. Second, you confirm that the symptoms the patient is having, the postural symptoms are due to hypotension. That is, the hypotensive events correlate with the symptoms as well. Before you label it is hypotension induced and take off the drugs. And then you see what are the drugs which the patient actually doesn't need. For example, the over-diuresing the patient, or the patient is for any reason on calcium channel blocker, they ideally shouldn't be. Take out all those drugs and then come to ACE inhibitors or ARNI which the patient is on, and then take them off. So that would be probably the last step. So that is step 1 to 3, and step 3 and 4 actually are more specific. Like even this is available online. I would urge you to just search for this. This is an ESC guide, heart failure register guidelines, which shows how to manage hypotension in an HFrEF patient. So it's a nice decision tree. I'm sure it will be useful for us if we keep it in our clinic as well. So symptomatic hypotension is a problem in hospitalized patients as well. And ARNI actually works better than enalapril. In fact, a 27% reduction. You can see that the confidence intervals is towards 0.7. So, the odds ratio is much less than unity. So it does much better than enalapril to prevent hospital hypotension in hospitalized HFrEF patients. The last issue which we have to discuss is the relation of death to hypotension in a heart failure patient. It is very clearly known that patients who are hospitalized for hypotensive events, for whatever reason, HFrEF patients who get admitted for hypotension have increased incidence of death as well. Even in this subset scenario, enalapril is worse off if you can compare to ARNI. So an ARNI patient who is admitted with hypotension over a period of 90 days, the chances of the patient dying is less than if the patient was on enalapril. The reasons I couldn't find out probably, and they've not discussed it either in that particular article. So the chance that you permanently stop ACE-ARNI after hypotension is more likely in this real-world study with enalapril rather than with ARNI. So you're more likely to continue ARNI even if the patient has hypotension, and even hypotension due to hospitalization for hypotension is lesser with ARNI compared to enalapril. So that's probably the last or the penultimate slide here. So when you have a patient with hypotension, first confirm that you are not over-diuresing the patient, especially in our part of the country where it's hot, humid weather. The patient can go into hypotension because of over-diuresis. The patient can have some other reasons, may have diarrhea, vomiting. So you see whether they're over-restricting the salt intake. So once we have ruled out volume depletion as the cause of hypotension, try to adjust the other drugs, take out the unnecessary drugs, take out any drugs purely used for antihypertensive agent, try to take them out, find out all causes of hypovolemia and treat it. And then if still hypotension persists, go to step 3 here. You might have to take out or reduce the dose of ARNI, which you may be able to initiate in future for the very reasons that these patients benefit a lot from these drugs. So in summary, the patient, like our index states, it is better to initiate ARNI as early as possible because the results are very clear and seen even in real world settings. These are not controlled studies, so it is a reflection of the real world practice. So our patient, like each will benefit from this drug, and switching enalapril to ANI wouldn't be a bad idea at all in these patients. Thank you, and we need after the discussion, we can very well have some points or comments from any of you.
What's your threshold in the
So if you ask personal practice preference, 90 is when I'm worried. I go up to 90, even we have initiated ARMY between 90 and 100. We don't get much hypotension at those levels. So actually, what explains with some data which they have can actually BP improves with ARMY. If you start at 90, as the LV function improves, your BP improves to 100 and beyond. Though we have not seen that in our practice, but less than 30 ml VGFR is also very, very important. So the nephrologist, I was sharing the session with the nephrologist. The feeling that the nephrologist is, you just go ahead, don't worry about the DM and writers. Because once when compared to all the benefits that the army is going to give for the heart, the typical blood pattern care even if it worsens.
30% is
But 30% increase. Any I see also 30% in creatinine is
One of the nephrologists actually when Chennai was studying the other day, it was very interesting. Of course, we all know that all CKD patients die because of heart failure or whatever cardiac cause. So he says that no renal patient should die with a normal kidney. So you go up and give creatinine, let it go up, but they should not die due to a cardiac problem. Like cardiac benefit, use it to the maximum doses.
Creatinine goes up to 3.6, urea 150. Still he is comfortable from 2.6. How to compromise kidney for the sake of life?
So one more thing, I observed like
Many patients come for like pre-transplant evaluation and they have LV dysfunction. We start on always LV function boost. We can give even with the creatinine 6 or 7 also.
Sorry, Dr. Sridhar was here all the time, we never knew.
Oh, sorry.
And we were talking big.
Sorry.
So now
Sorry,
we
sir.
keep quiet for some time.
Yes, yes.
Good afternoon, everyone. Delighted to be here among all the nephrologists. And I'm Dr. Sridhar, practicing as a nephrologist and a transplant physician at Nepal Hospitals. So, most important is the crosstalk in the heart and kidney. So, as you all know, as the kidney function worsens, the GFR decreases from stage 1 to stage 5. The prevalence of heart failure increases. At the same time, you see a patient with heart failure, around 30 to 40% will have GFR less than 60 ml per minute per 0.7 liters. So this is a crosstalk between heart and kidney. So 20 to 40% of heart failure patients have serum creatinine. Rise of serum creatinine more than 0.3 mg per deciliter of a hospitalization for heart failure. And around 50 to 60% of heart failure patients have eGFR of less than 60 ml per minute per 0.7 liters square. And similarly, if you take patients who are suffering from chronic kidney disease, as the chronic kidney disease progresses from one stage to another, nearly 20 to 40% of people will suffer from heart failure. So this is a imaginary case scenario. A known case of heart failure since 3 years and chronic kidney disease since 2 years. Currently on initial dose of ACE inhibitor or a blocker, and recently complaining about swelling on the legs and tiredness. So he's complaining of easy fatigability since last 2 weeks. So the clinical history and investigations are LBF 25%, serum creatinine of 2 milligrams per deciliter, and eGFR of 40 ml per minute per 0.73 meters square, and potassium of 5.1. And reports indicate renal dysfunction along with hypokalemia, which makes the choice of heart failure with reduced ejection fraction therapy even more difficult. So most of the times, the renal dysfunction is an unwanted barrier with heart failure therapy. So even if we want to initiate or if we want to reach the guideline-directed medical therapy, the renal dysfunction is an important barrier. The RAS inhibitors have shown incremental benefit on improved quality of life, reduced hospitalization and mortality rates. However, if you initiate a patient who is already having renal dysfunction on RAS inhibitors, worsening of renal function is common during heart failure therapy and has been associated with decreased survival, increased hospitalization, and disease progression. See, at this point, I want to tell you that the common notion among the nephrologists previously not to initiate any patient on ACE inhibitors or ER blockers if straight away his eGFR is less than 30 ml per minute per 1.7 liters. So this is the previous concept. However, if the patient is already on ACE inhibitors or ER blockers, and during the course of his illness, if his GFR is fallen below 30 ml per minute per 0.70 meters square, you can continue ACE inhibitors or ER blockers. That was a previous notion. However, as the concept of heart failure and the quality of life is evolving, so the quality of life is more important. We all know that the major international trials, they have excluded the chronic kidney disease patients as far as the guideline-directed medical therapy is concerned for treatment of heart failure because of this fear. So we all have this therapeutic nihilism, whether it is a true worsening of renal failure or is a pseudo worsening of renal failure. So this is all nothing but the hemodynamics. And apart from the macrovascular disease of renal arteries, we should also keep in mind the microvascular disease in the kidneys. So as Sir told, some of the patients, they may not tolerate ACE inhibitors or beta blockers. So this can be because of the presence of microvascular disease. So the pseudo worsening of renal function as soon as a patient is initiated on ACE inhibitor or AR blocker, there are certain clinical indicators which you can differentiate. Suppose if the patient is improving clinically, suppose the patient quality of life is improved, then even though his creatinine worsened or his EGFR worsened, then you can simply monitor the patient and you can simply reassure the patient that this will stabilize over a period of time. So at this point, you need not reduce the dose or you need not entirely stop the drug. So you can continue, albeit with a careful monitoring. So definitely, what is your choice of RAS therapy given renal dysfunction for patients like this? So ACE inhibitor, AR blocker, or sacubitril valsartan. So the latest data in our hand, obviously the choice of therapy will be the RAS. Even the KDIGO guidelines, the KDIGO controversies clinical conference, they have also advocated as the first line of therapy will be sacubitril valsartan for a chronic kidney disease patient who is suffering from heart failure. So all the previous studies like SAVE, SOLVE, RAILS, they have shown that there is increased risk of mortality in HFrEF patients with worsening of renal function. Stopping RAS inhibitors in patients with heart failure may lead to repeated cycle of worsening of renal function, clinical deterioration, and death. So as we discussed previously, if we stop, again the patient will enter into a vicious cycle of heart failure, poor quality of life, further worsening of renal function, and ultimately death. So need for newer therapy in managing HFrEF in CKD. We all know that the traditional therapies like ACE inhibitors, AR blockers, or beta blockers, they have targeted two neurohormonal pathways. One is RAS activation, second one is a sympathetic activation. These two pathways, they drive detrimental hemodynamics. However, the third pathway is the natriuretic peptide pathway. This pathway is beneficial in heart failure patients. Actually, the patients who are suffering from heart failure, they are deficient in natriuretic peptides. So this is the pathway, the natriuretic pathway, which is targeted, and this found out to be having lesser side effects when compared to the traditional drugs, and more benefits in terms of improving quality of life and mortality benefits. So sacubitril valsartan, a novel therapy, has a proven better kidney safety benefits compared to RAS inhibitors. So recent American College of Cardiology 2021 consensus also direct to ARNI approaches. So this is all the data. So sacubitril valsartan is proved to be efficacious, is proved to be safe in terms of worsening of renal function, is proved to be safe in terms of preservation of renal function in the long term, and most importantly, the dosage initiation. We have the UK Heart2 trial, which included patients, UK Heart3 trial, which included patients of EGFR up to 20 ml per minute per 1.73 meters square. I think most of the nephrologists or the cardiologists have experience now of starting this drug even at the GFR of 15 ml per 1.73 meters square, or those who are already on hemodialysis. So most importantly, hyperkalemia. So when compared to ACE inhibitors or AR blockers or mineralocorticoid antagonists, hyperkalemia is not statistically significant with sacubitril valsartan. So we all know the management of hyperkalemia depending upon the serum potassium levels. If potassium is more than 6, then you have to stop the potassium sparing medications, injection calcium gluconate, beta-2 receptor agonist, insulin plus dextrose. And if potassium is between 5 and 6, you can carefully monitor. And if the patient is already on other drugs like potassium sparing diuretics, sometimes beta blockers and even heparin can also contribute to, digoxin can also contribute to hyperkalemia. And before reducing the dose of this sacubitril valsartan or entirely removing this, we can remove the other drugs which are contributing to hyperkalemia. And still the patient is not able to maintain his serum potassium levels despite the dietary advice, then we can advise patilomer or sodium zirconium cyclosilicate, which we are expecting in the coming 1 to 2 years, which maintain the patient in the range of normal potassium levels. So to summarize, sacubitril valsartan has proven better kidney safety profile in terms of hyperkalemia or worsening of GFR over the long term. And most importantly, the quality of life is more important as far as the chronic kidney disease patients are concerned. So they can lead a better quality of life. Those who are in dialysis also, we observed that they can do their own work. The dependency on other family members has been decreased. Thank you.
Non-dialysible drug is hypoprotein, but probably non-dialysible.
So actually, any ER blocker or beta blocker is not dialysible. It's an ER blocker only, it is not dialysible. That's why it's a valsartan non-dialysible.
So
Even
how much is safety using it in dialysis patients?
Actually, in dialysis patients, the problem is first of all, we advise them to take daily 3 times hemodialysis. Even strict dietary control. Third thing is, we will start on a low dose. Why? Because we don't know how these patients react. Sometimes they develop hypotension. There is every chance of clotting of the dialysis. Very, very important. So patency of baby tissue is very important. So usually we start 25 ml. And on the day of dialysis, usually we don't advise the patient to take that. And measure the potassium levels if possible weekly 2 times, or at least weekly once. See, the dialysis patients, they will tolerate 5.5 to 6 potassium easily to normal population.
If the creatinine starts rising after starting the RNA, what do you think the laboratory values, at which point then we have to consider discontinuing the drug? Is there a cutoff like that, or there is no need to worry about rising creatinine if the clinical improvement is there?
Usually the data says 30% increase in not only RNA, any inhibitor, after you start, within the next 7 days, you have to measure the GFR. If it is less than 30% rise, then you can safely continue, even for a normal patient. But if you take a patient who is suffering from heart failure, who has all many different hemodynamics, like you are decongesting the patient, and at the same time you are lowering his blood pressure. So you can expect 40 to 50% rise in creatinine, not a simple 30% is affected the normal patient. So up to 50%, you can definitely monitor and you can continue the treatment, provided the clinical condition is not important.
Thank you.
So one more thing, sir, spironolactone, how are you, can we give in patients on dialysis?
Actually, mineralocorticoid receptor antagonists, dialysis patients, there are no trials which have better, which came better.
So we increase potassium like normal patient, because in patient with end-stage renal disease, there is no dialysis. So there is no point that as per mechanism, it can't increase the potassium.
See, there are 2 sets of patients. One who have residual renal function and residual renal function at least 200 to 500 million now.
That's it.
Thank you, sir.
Thank you, sir.
So moving to the next topic. So what is the right treatment for heart failure with reduced left fraction by Dr. Raju Garu?
Good afternoon, everybody. I think my job is made little easier by the earlier speakers. Talking about the army and then the mechanism of action, and then especially the presence of renal failure and with the addition of nephrologist as well. Now move on to the right guideline directed medical therapy for FF patients in need of the arm. We just see the in India, we know that the mortality rate in FF patients is increasing with time, and the cumulative mortality at the end of 3 years is approaching almost 46%, starting from 9.7% in hospital mortality. And the essential way to combat heart failure is to improve the patient outcomes, and current guidelines recommend guideline-directed medical therapy. Just look at the patients who are not on guideline-directed medical therapy. They have 29% increased risk of mortality compared to those who are on the guideline-directed medical therapy. Needless to say that the patient has to be started as early as possible on the guideline-directed medical therapy to have the appropriate results. The question is when to initiate guideline-directed medical therapy and choosing the right guideline-directed medical therapy and how to achieve the optimal therapy. The recent ACC 2021 consensus recommends that start GDMT immediately. So there is no need to wait. Then you can just start the guideline-directed medical therapy as early as possible. The first step for successful heart failure treatment is to initiate, add, and switch to the newer evidence-based guideline therapy for HFrEF patients. The important concept is starting at low dose and titrating slowly upward as tolerated. As we have discussed, most of the drugs which are given for heart failure, they do have the hypotensive effect. All of them have the effect of increasing the potassium. So we have to be very careful when we are simultaneously starting a lot of drugs which produce the same hemodynamic effects. And the recommendation is an ideal time to consider therapy optimization is during the hospitalization itself. That's the best time when you have the control over the hemodynamics. You are monitoring closely all the hemodynamics, including the urine output, the rise in creatinine, the hemodynamics, the blood pressure fall, everything. So we all know that these are the 4 pillars of mortality beneficial drugs. ARNI, beta blocker. The first group includes not only the ARNI, the S inhibitor, ERB, MRAs, and then the SGLT inhibitors. These are the trial evidences which are shown on the bottom. S inhibitor or ERB, beta blocker, MRAs having 30% mortality, and then the ARNI 16% mortality benefit, and then the SGLT inhibitors. This is how there are 2 traditional. The traditional way of starting the mortality beneficial effect drugs are in a serial way, the one after the other. But there is a simultaneous or rapid sequence strategy is more believed nowadays, where you start. Just look at the slide below. The ARNI can be initiated. There were a lot of concerns when the ARNI was introduced in the beginning that they have to be started after stabilization, maybe after the first follow-up. Then the other trials came, like the transition, where they have moved to the pre-discharge initiation of ARNI, and now it is you can just start ARNI on day 1 itself. ARNI, beta blocker, MRAs, and SGLT inhibitors initiate, up titrate as patient tolerates, and then stabilize, and then achieve the target dose in the due course of time, or many weeks to go. choosing the right combination therapy, the ACE inhibitor, ARNI, and then the ARBs, MRAs, evaporative and beta blockers. Of course, in selected patients, isosar nitrate and hydrogen combination. The guidelines recommend that optimal outcomes are achieved with the target dosing of. It is not just enough. You just start the dose. Try to escalate the dose to the maximum beneficial or the target dose to have the maximum benefit. Let us have a couple of slides which emphasize the same fact. So the problem here is the combination of drugs. The drug cocktail is going to have increase the risk of drug versus drug disease interactions, adverse events, inappropriate drug prescription, underuse of effective treatment, medication errors, and poor adherence to the pharmacological therapies. To assess the tolerability of medications and best assess the trajectory of heart failure, it is often necessary for patients to have more frequent follow-up visits, especially after the initiation and titration of the therapy. So this is the ACC 2021 consensus recommends an algorithm for initiating the GDMP in heart failure patients. So for patients who are having more than eGFR of 30, you can add aldosterone antagonist. For patients with meeting the same eGFR criteria, we add SGLT2 inhibitors and then titrate them. If the patients are having volume overload, titrate with the diuretic dose. And for them who are having overdiuresis, especially when you are giving SGLT2 inhibitors and the RNA, try to reduce the dose of diuretic. The key lies in reducing the diuretic dose at appropriate time. If you don't reduce it, the patient will land up in a vicious cycle of postural hypotension and then again worsening renal function, and then you will land up in that vicious circle. The hydrogen isosarbitenitrate in selected population, and then if the heart rate is beyond 70, even after the maximally tolerated beta blocker, when you are compromising the blood pressure fall, you add the evaporating to reduce the heart rate and then maintain the heart rate. 2021 consensus, this has been a direct to ARNI approach, is now very well accepted. The ARNI has an expanded role focusing on the optimizing therapy for HFrEF patients for superior benefits in de novo patients and rapid improvement not only in symptoms but also in the physical functioning and quality of life. All of you will agree that once the ARNI has started, the patient improvement for the first follow-up itself, you see the wonderful results. And cardiac reverse remodeling effect is independent of background therapy with ACE inhibitors or ARBs. How to achieve optimal therapy? The treatment intensification is seen in the first 2 to 4 months and 1 to 4 week cycles, serial evaluation of patients, symptoms, vitals, examination findings, and lab findings. If the volume status requires treatment, adjust the diuretics, follow up 1 to 2 weeks. If euvolemic status is achieved, patient is stable, either start or increase or switch to the GDMT, follow up every 2 weeks. After GDMT is initiated and titrated to achieve maximally tolerated doses, patients with chronic heart failure patients should be evaluated on a regularly scheduled basis. This is how they initiate. If the patient is previously on ACE inhibitor, a wash-off period of 36 hours should be allowed. If the patient is not on ACE inhibitors, you can straight away start the ARNI. If the patient is on equal to or less than 10 milligrams of enalapril or equivalent of 160 milligrams valsartan, start with 50 BD. If the patient is on more than 10 milligrams dose, then you can directly start with 100 milligrams twice daily. In 2 weeks, assess tolerability. If possible, increase the dose to a target of 200 milligrams BD. And this is very interesting. Up titration of sacubitril valsartan in heart failure with reduced ejection fraction. 61% of patients post-discharge achieve target dose by week 26. That means still 1/3 of the patients have not achieved target dose. And sacubitril valsartan up titration achieve target dose with simultaneous initiation of or up titration of the beta blockers and MRAs. And if you just see the mortality benefit, 63% reduction in risk of all-cause mortality with sacubitril and beta blockers and MRAs added. Top in the list, 63% highest all-cause mortality reduction has been observed with this triple combination. Why is there a need to uptitrate the dose of sacubitril valsartan? This is what we have been discussing. The favorable effect of clinical course and optimal course of sacubitril valsartan is seen only with the 200 milligram dose. The mean increase in EF tend to be marginally greater in medium or high dose of sacubitril valsartan compared to low dose. The higher the dose of ARNI, the more is the benefit. Dose optimization in different scenarios. This has been very well discussed by the previous speakers. So even in mild, moderate or severe EGFR reduction, you are justified in starting ARNI and continuing ARNI. The dose titration for hyperkalemia, again, discussed very well in the previous speakers, and it will be a repetition. Just concentrate on the first slide: diuretic therapy, dietary salt restriction, and diarrhea or vomiting. Inquire about these two things. The patient is having that, adjust the diuretic doses, and then try to concentrate on the dietary potassium and manage the hyperkalemia. So this is the concluding slide. Initiating the right GDMP like ARNI to get the best results. Why? Absence of GDMP was associated with independent associated increased mortality. When early initiation is the best. How long? Hospitalization is the how hospitalization is the best time or the ideal time to consider therapy for optimization. And we have to understand that 75% of Indian patients of HFrEF do not receive optimal therapy. So only 1/3 are receiving optimal therapy. We need to increase this proportion and give the maximum benefit to all the needy patients. Time is now to initiate and uptitrate the ARNI combination for your HFrEF patients to keep them alive and out of hospital. Thank you very much.
How many percentage of patients of the university practice are going for ideal 200 milligrams BD of ARNI?
200 milligrams, to be frank, maybe 10% of my patients as of now.
We see, though we study several times this, we fail to reach those doses. Probably it's an inertia, or Indians behave differently. I don't
Maybe there is Western data, sir.
Yeah.
Our BP with the
Why ARNI take the beta blockers alone? See, all of us agree that how many or what proportion of our patients are reaching the target dose of beta blockers. If you just start with say 25 milligrams BD or 25 milligrams of metoprolol or 50 milligrams, your heart rate of 50 is reached. You can't go to 100 milligrams because you need to add ivabradine as well, and then there's a lot of other drugs which will lower the blood pressure. And a significant proportion of your heart failure patients, their baseline blood pressure is around 90 to 100. And you are adding a SGLT2 inhibitor, you are adding a beta blocker, you are adding an ARNI, and you are giving MRA. So we have to understand that there are constraints for us, and probably, as I said, the racial differences among the Asians or Indians and compared to the other Western population. Probably we need to reconsider, and we need to have the Asian guidelines or the Indian guidelines for our this.
More than that, we need to tailor therapy also for the individual patient. Actually, the hardly I don't remember any patient complaint reaching target of 200 milligrams. Probably some inertia is there with the doctor itself. Because the cost itself is a little bit higher, and the patient reaching the hypotension at the only thing is we can decrease the dose of diuretic once we increase the dose of ARNI.
People who are having hypertension with heart failure, those are the subset. I remember at least 10 of my patients are on 200 milligrams BD. Because fortunately their blood pressure is allowing us to go.
And as AC inhibitors also, the target dose of phenylephrine is 20 milligrams.
20 milligrams.
But always
I remember a patient, 92 years old. He came with evolved anti-1 He was a gas like APD elsewhere. He came in the initial presentation. I am still following him because at the time of presentation, his age is around 84 or 85, I think. Okay. Evolved At that time, I admitted that I took concern because considering his age, I didn't put him on angio also. I put him on only simple diuretic and beta blocker only. Every time I see him, his BP is around 90 and 100 only. But I didn't dare enough to put ARNI in that age also. Because he's not having complaint, but recently, last admission, he came a couple of weeks, maybe. He came with partial hypotension. So I told him to take, as if he's symptomatic only, to take diuretic and beta blocker also alternate. That too, bisoprolol 1.25 alternatives. I didn't dare to put ARNI also for him. Simple single antibiotic and statin and diuretic if necessary. He is now 93. What else I can log him? I don't know. That's why you
Yeah,
have to create a corner.
risk of postural hypotension is more.
Treatment of heart failure, you need beyond the science, you have to have art levels. That lies especially titrating the diuretics. When you should decrease the doses of diuretics is a very important step in doctor.
Heart failure prescription without a diuretic, especially, looks crazy to somebody else.
Yeah.
Now, if a patient, if you are seeing a patient a long-term follow-up, somebody with the heart failure treatment without any diuretic, so it looks crazy to any physician also. So, heart failure treatment some loose comment
Write down sir, SOS. Edema or dyspnea, SOS and come to me.
And sir, more than symptomatic relief also, there is unlike there is some benefit also, mortality benefit also. So, but we can't offer him if there is such guy, 92-year-old guy, no symptoms, what medicine mortality benefit you are going to give, we don't know. We are only leave.
I have seen a patient, year of 20. He was admitted somewhere else. They started diuretic in hospital, and he admitted me for severe hypotension. So we stopped the diuretic, and he gradually recovered. And he doesn't require any diuretic. He says he is fine. He comes with CF of 20, and he never says he has PND, orthopnea, edema. And apart from this facing with army and all beta blocker, he doesn't require diuretic.
These are all diuretics.
So the heart lies who requires what dose of diuretic increase heart failure is the
And with ARNI, afternoon will be very much reduced as well. And with low EF also, his cardiac will increase and blood pressure also somewhat increases in some patients.
Maybe in the long term.
In the long term.
If you see the prescriptions from
Not in acute failure, but in the stable.
Arab countries, when a lot of Indians go there, they come. I belong to Karpa district, where a lot of people go to Gulf and then come back. Straight away, if you see any prescription, there will be 20 milligrams of Gestrel. Gestrel is Disnoprid. Irrespective of the blood pressure, they start on Gestrel and Conquer. Every prescription will have a Gestrel and Conquer of 5 milligrams. You'll be surprised that they are tolerating. When they come here, no, they just land in Chennai and then from there take a taxi and come to Nellore. And then once they see that, I'm surprised to see that drugs, they just should throw all the drugs on my table. When you see that, Gestrel 20 milligrams is given like a textbook standard top dose. The maximum dose is given for every patient, irrespective of checking the blood pressure. When you check it, they are tolerating. Probably it is time for us.
They are traveling and all this.
That's why we should also think that probably we are stopping at one point and then not going beyond that. As you are pointing out, no, we should again think that probably we can step up in selected population. It's not in all patients. That's what I mean.
We'll be going on to the next session. Next talk. Tide extension catheters and coronary interventions by Dr. Yudhishthir.
Can you please
Introduce yourself.
Good afternoon, sir. I am Dr. Yudhishthir. I did my DM cardiology from Osmania. I am working as a consultant cardiologist at Lanta Hospital, Guntur. Today I am going to speak about guided catheter extensions. First of all, I will go briefly through a case scenario. Recently, a 52-year-old man presented with acute inferior MI. We did an angiogram. We showed that mid-RCA is totally occluded. Now we can see that the RCA is quite arches and it is looking like a shepherd foot one, and the guide is also not coaxial. We could not advance the wire even with the help of a balloon support. Later, after advancing the guide extension catheter, the guide is deeply seated inside the towards the aortic crest on the wall of the aorta, and we could successfully wire pre-direct and stent the RCA. We got a good result with kidney 3 flow. PCI of complex coronary lesions is particularly challenging, especially with transradial approach. Failure to advance balloons and failure to stent deployment occurs occurs in 3% of the procedures, especially with calcification, marked tortuosity, or in total occlusions. Radial approach is the most widely used one because of its efficiency and low complication rate. But the strength of support offered by the radial approach is significantly lower when compared with the treatment of femoral approach. The most common cause of procedural failure is due to failure to deliver the equipment towards the site of lesion. This is mostly due to the poor backup force and the poor coaxial alignment, and also due to increased tortuosity of the target vessel. To overcome these obstacles, many strategies like improved lesion preparation, use of stiffer guidewires, use of a bodywork technique, or an increased guide support has been employed over the years. Various techniques to increase the guide support, like passive techniques like changing over to a larger guide or switching to an amplus left over the Judkins circle, or the active techniques like deep intubation of the same guide, or use of a balloon or a guide extension catheter or a micro catheter. Here we can see the same guide catheter has been deeply intubated inside up to the mid RCA during the time of stent deployment, and even up to the distal RCA, which gave a good support for post dilatation. But here there is a increased chance of dissection, perforation, or thrombosis. With the advent of guide extension catheters, there is increased guide backup support, which is very crucial in complex procedures. We can attain a success rate of above more than 90%. With as little as 5 millimeters of extension, the guide catheter extension significantly increase the backup support of the standard 6-French guide catheter. Apart from facilitating stent delivery in calcified and tortuous arteries, they help in engaging the coronary arteries of anomalous origin in graft PCA and also in CTO PCA, and also in distal vessel stenting for distal drug or device delivery, and also for foreign body retrieval. Various varieties of guide extensions were available. They are like the guide liner, the trap liner, guidezilla, telescope, the guideon, expressman, and the arterial system. This is the guide liner catheter, first FDA approved in 2009. This is a 150 centimeter long catheter which has a 25 centimeter rapid exchange section and a 17 centimeter half pipe and a 108 centimeter push rod. This is available in 5 sizes. The inner diameter of the guide extension guide liner is 456 and the outer diameter is 065. This is the guidezilla catheter developed by Boston Scientific. This is FDA approved in 2013 and is available in 4 sizes. This is the trap liner catheter developed by Teleflex. This is similar to guide liner V3, except for that the rapid section is only 13 centimeters, and there is a trapping balloon which will help in trapping the wire and the microcatheter if needed. This is the telescope catheter which is developed by APT Medical. Sorry, Medtronic. This is the expressman catheter developed by APT Medical. This is the only guide extension catheter which has side holes. This will maintain the blood supply for distal artery even in the presence of severe stenotic lesions. Coming to comparing these guide extension catheters, the guide liner and the trap liner has a rectangular push rod, whereas the guidezilla and the telescope had a rounded push rod. The internal diameter, coming to internal diameter, the guidezilla has 057, comparably larger compared to the guide liner V3, the trap liner, and the telescope catheter. The outer diameter is same in all the catheters. Why use a guide extension catheter? It increases the backup support, coaxial alignment to deliver the device in the calcified and tortuous vessels, for PCI in anomalous origin coronary arteries, for graft PCI, for PCI post TAVI, or in the or CTO PCI, drug delivery in the coronary, the thrombus aspiration, or imaging in the proximal coronary bed, and femoral or a foreign body removal or retrieval of the entrapped equipment. Here we can see after deep engagement of guide extension, into the SVG graft, the guide has been deeply seated into the aortic cusp and against the aortic wall. This gave a very good support, and they have successfully done a PCI to this SVG graft. In this case, it is in which there is difficulty in engaging the left main. Followed by using a floating wire into the left LED, they could advance a guide extension catheter which helped in successful PCI. In the case of reverse card technique, if one can advance a guide extension catheter up to the proximal cap of the CTO, the distance traversed by the retrograde guide wire into the guide extension can be very much shortened, and this will promote the successful return-led approach. How to deliver a guide extension? Either by direct advancement or balloon anchoring technique, or a balloon-assisted tracking, or by inchworming. If there is no proximal lesion, we can carefully directly advance the guide extension catheter, or by placing a small 1.5 by 15 semi-compliant balloon distally as an anchor, and we can slowly advance the guide extension catheter. The safest ones are the balloon-assisted tracking and the inchworming technique. Coming to balloon-assisted tracking, we keep a small 1.5 by 15 semi-compliant balloon halfway in and halfway out of the guide extension catheter, and we will slowly advance the guide extension catheter distally up to desired location. This will prevent the vessel wall trauma. Whereas in case of inchworming technique, similar to balloon-assisted tracking, we will keep the balloon halfway in and halfway out, and we will deflate. Only while deflation, we will gradually advance the guide extension catheter. This will further reduce the vessel wall trauma. Or what are the complications associated with guide extension catheter? Equipment deformation, mostly when passing the guide wire or the stents at the site of guide extension collar, or during removal of the guide extension, can lead to entrapped stents or anything. When deep-seated guide extension, it can lead to ventricularization or damping of the pressures. When a forceful injection is given at this point of time, it can lead to dissection, a vessel wall trauma leading to thrombus. Particularly in case of SVG PCI, if we give a forceful injection without holding the guide extension, it can distally migrate into the SVG graft. Fractures of guide extension can happen when we forcefully advance the guide extension against a stent. It can lead to longitudinal stent deformation. Here we can see the stent being stripped away from the balloon. Here we can see the guide extension wire damage when it got stuck at the location of the collar of the guide extension. If we take a smaller size guide extension compared to guiding catheter, the wire can move outside the guide extension movement and within the guide. What are the tips and tricks for a guide extension? Always keep the push rod under the towel. Delivery, better to prefer the balloon-assisted tracking or an inchworming technique. Always advance wires and stents under fluoro only. Do not advance proximal collar outside the guide, and always check for the compatibility of the guiding with the microcatheter or a rotablator burr and stent sizes beforehand only. This chart shows how we can what catheter can be used inside which guide extension. We did around 19 cases in the past 1 year. All of them were radial, using a 6-French guide catheter and a 6-French Boston scientific using a monorail technique, using balloon-assisted tracking. We got 100% procedural success with very limited complications. Apart from their primary use in increasing the backup support, they are increasingly used in complex high-risk indicated procedures. It allows the operator to change the strategy during the procedure in difficult anatomy due to its rapid exchange nature. Thank you.